Imagine this scenario. You are about to undergo a total hip replacement. It's a major surgery. You know your body has a specific, rare condition that makes surgery dangerous if not managed perfectly. So, you do everything right. You get the written orders, you wear the medical bracelets, you bring your own emergency medication. You are the textbook definition of a prepared patient. And then, minutes before you go under, the anesthesiologist looks at you, refuses your specialist's orders, and asks if you want to read his medical textbook. That is not a hypothetical. That is the exact situation Christin Disler faced. She's the wife of Rick Disler, the founder of the advocacy group My Adrenal Life. And her story is going to anchor our conversation today.
It's a terrifying story, Jake, and honestly, it's a perfect case study for why the old model of doctor knows best is dangerous, and why family advocacy isn't just nice to have, it is literally a life-saving mechanism.
Christin posted a detailed account of this on the My Adrenal Life Facebook group titled When Advocacy Becomes Necessary. And Rachel, I want to dissect this not just as a dramatic story, but as a systemic failure. We need to understand the medical mechanics of why the doctor was wrong, but also the cultural mechanics of why he felt comfortable ignoring her.
Absolutely, because Christin has secondary adrenal insufficiency, or SAI. We need to start there. For most of us, if we get cut open for a hip replacement, our adrenal glands flood our system with cortisol. It keeps our blood pressure up, it manages inflammation, it keeps us alive during trauma. Christin's body doesn't do that.
Right. She describes it as her body not being able to mount a stress response. So without external cortisol, her blood pressure bottoms out, she goes into shock, and she could die. That's the stakes.
Exactly. So let's look at her preparation. It was impeccable. She saw her endocrinologist a week prior. They wrote up a stress dose plan, specifically using Solucort, which is hydrocortisone. She called the surgeon, she called the surgery center. Everyone said yes. Check, check, check.
And yet, she hits a brick wall in the pre-op room. The anesthesiologist comes in and says, I don't need those orders. He tells her that everyone gets steroids in his cocktail and that his drugs are stronger than what she's asking for. He even told her, and this part blows my mind, that a total hip replacement isn't a major surgery for her condition.
That statement reveals a fundamental misunderstanding of adrenal insufficiency. And this is where we need to get technical for a moment, because the devil is in the pharmacology. The anesthesiologist was almost certainly referring to dexamethasone.
Okay, break that down. He said his drug was stronger. Is dexamethasone stronger than Solucortef?
In terms of anti-inflammatory power, yes. Dexamethasone is incredibly potent for stopping swelling and preventing nausea. That's why anesthesiologists love it for joint replacements. It helps you wake up, not vomiting. But here is the critical difference. Dexamethasone has zero mineralocorticoid activity.
Mineralocorticoid activity, that refers to salt and water retention, right?
Precisely. Hydrocortisone, which is what Solucortef is, mimics the body's natural cortisol. It helps retain sodium and fluid, which keeps your blood pressure stable during the massive trauma of surgery. Dexamethasone doesn't do that. So he was giving her a drug that stops inflammation, but leaves her wide open to hemodynamic collapse.
So when he said, my drug is stronger, he was comparing apples to oranges. He was treating inflammation while she was trying to treat a life-threatening hormone deficiency.
Right. And this is where the medical book comment becomes so ironic. He asked her if she wanted to read his book, implying she didn't understand the drugs. But actually, he was applying a general rule, dexamethasone is great for surgery, to a specific exception where it fails. The Endocrine Society guidelines are very clear on this. Patients with adrenal insufficiency need hydrocortisone for major surgery because of that mineralocorticoid coverage. He was factually, medically wrong.
But he held all the power. And this is the part of Christin's story that I think resonates with anyone with a chronic illness. She writes, it stopped feeling collaborative. It felt like an ego conversation. She's lying there, vulnerable, about to be cut open, and she has to argue for her life.
And she did something incredibly brave. She asked for her bag. She had brought her own oral stress dose as a backup plan. She took it right there in front of him. That act of defiance probably saved her from a much worse outcome during the surgery itself.
But the story doesn't end when she goes under, because the anesthesiologist was also wrong about the recovery. He said she'd be out in an hour. Instead, post-op, she's crashing.
She describes being lethargic, feeling like she would pass out when they sat her up. These are classic symptoms of looming adrenal crisis. Her blood pressure is likely dropping because, remember, the dexamethasone isn't holding her fluid status.
And this is where the family advocacy part of the prompt becomes critical. Christin is barely conscious. She can't argue anymore. Who steps in?
Her husband and her son. And this is vital. The husband didn't just stand there holding her hand. He observed, he listened to the anesthesiologist talking to the nurse, and he interjected. He told them she needs more steroids. He advocated until the anesthesiologist finally, and probably reluctantly, ordered 50 milligrams of IV Solucortef.
And the result?
Christin writes, within 20 minutes, I was able to function. It's the difference between a car running out of gas and filling the tank. The response was immediate because it was the physiological key that was missing.
It's chilling to think what would have happened if she didn't have that red bag with her own pills, or if her husband hadn't been in the recovery room.
She likely would have ended up in the ICU, or worse. Unmanaged adrenal crisis has a high mortality rate, and the tragedy is the medical chart would have just said surgical complication, not provider arrogance.
Let's zoom out a bit. You mentioned the ego conversation. Historically, medicine has been very paternalistic. The doctor is the captain of the ship, and the patient is the passenger. But this story highlights a shift that's been happening since the 1970s, really, starting with the Patient's Bill of Rights.
It is a slow shift, though. The Patient Safety Movement Foundation talks about the Swiss cheese model of medical error, where layers of defense fail one by one. Usually we think of the doctor as a defense layer, but in this case, the doctor was the hazard. The patient and her family had to become the defense layer.
It changes the definition of a good patient. A good patient used to be compliant. Now a good patient, especially with a rare disease, is informed, prepared, and occasionally difficult.
I'd argue they aren't being difficult, they are being professional. Christin brought written records, she brought the bracelets. She was operating like a project manager. The anesthesiologist was operating on autopilot. That's the friction point. Rare disease patients cannot afford autopilot.
So let's talk about the backup plan. Christin's post explicitly lists what that means. It's not just a mental idea, it's physical gear.
Right. She lists 4 or 5 concrete things. First, documentation. Not just saying, I have SAI, but handing over a paper from an endocrinologist. Second, visual cues. She had red silicone bracelets on both wrists. Third, the go bag. She had her own medication, her own injection kit. And fourth, the designated advocate.
That fourth one is interesting. We often think of emergency contacts as just people to call when it's over. But for chronic illness, the advocate is a participant in the care.
They have to be. When you are waking up from anesthesia, your cognitive function is impaired. You literally cannot advocate for yourself. You need a designated hitter, someone who knows the medical plan as well as you do and isn't afraid to make things awkward to keep you safe.
Make things awkward. That's a great way to put it. We are socially conditioned to be polite to doctors. Christin's story gives us permission to break that social contract when safety is at risk.
Exactly. Christin says explicitly, you are not difficult, you are informed. That is a mantra every patient needs to hear. The anesthesiologist tried to shame her with the medical book comment. He tried to make her feel small. If she had succumbed to that shame, if she had said, okay, he's the doctor, I shouldn't cause a scene, she might not be here to write that post.
There is also a nuanced point she makes about the rest of the staff. She says the nurses were wonderful, the surgeon was kind. It wasn't a total system failure, it was a specific bottleneck with one provider.
That's common. Nurses often catch these things, but they are stuck in a hierarchy where overruling an attending anesthesiologist is professionally dangerous. Christin notes that the nurses knew about the Solucortef in stock. They were ready to help. But the order had to come from the top. That's why the patient family advocate has to be the one to push. They are outside that professional hierarchy.
It's a powerful reminder that you are the only person in that room with 100% skin in the game. The doctor has other patients. You only have one life.
And for the adrenal community specifically, this is a wake-up call. We have guidelines. The 2020 Joint Guidelines for Glucocorticoid Management are very specific, but guidelines don't administer themselves. You have to be the carrier of that knowledge. You can't assume the specialist in the room has read the latest paper on your rare condition.
So if we distill this down to a takeaway for our listeners, it's about constructing that safety net before you need it. Christin didn't wait until she was groggy to explain her condition. She did the work weeks in advance, and she still met resistance.
And that is the scary part, but also the empowering part. Even when the system tried to fail her, her backup plan worked. She took her own pill. Her husband spoke up. The backup plan isn't for when things go right. It's for when the expert in the room gets it wrong.
Christin Disler's experience is a masterclass in survival through preparation. It's uncomfortable to think we have to second-guess our doctors, but as she proved, collaboration is a two-way street. Sometimes you have to force the traffic to stop.
Well said, and kudos to her for sharing it so transparently. It takes a lot of guts to say, I was scared, I was vulnerable, but I stood my ground.
Absolutely. If you know someone managing a chronic condition or anyone preparing for surgery, send this episode to them. It might just be the push they need to pack their own backup bag.